Hello, doctors. Today we are going to study about migraine. A migraine, a common but highly disabling neurological condition that frequently presents in both IPD and emergency settings. So, we'll discuss more about in a clinical basis. So, migraine it is a severe headache that causes throbbing, pulsing head pain on one side of the head. And the headache phase of a migraine usually lasts at least for 4 hours, but it can also last for days. So this headache get worse with the physical activity, bright lights, loud noises, strong odors, etc. So, migraine is not just a headache, it is a neurovascular disorder affecting a significant portion of the population, and it has a huge impact on quality of life and productivity too. And so, in this lecture, we will cover its clinical presentation, pathophysiology, and how to manage it effectively in both outpatient and inpatient settings. So, this is the brief introduction of what is migraine. We'll move forward to the classification. So, classifications, migraine can be broadly classified into two main types, like with and without aura. So, with migraine with aura is a uh, classical type, and migraine without aura is a common type. And so, what do you mean by aura? With aura, without aura. So aura, it refers to a neurological symptoms like visual changes that precede the headache, or it is like before getting a headache you will there will be visual changes which will precede the headache. So that is what is called as aura. So, other classification of migraines are chronic migraine, which is defined as having more than 15 headache days per month. And there are other rare variants also, which includes hemiplegic migraine, where patients have temporary weakness, retinal migraine, which will affect one eye, and migraines in children like abdominal migraine, menstrual migraine, status migrainosus, vestibular migraine. So there are these are the different other types of migraine. So classical classification types of migraine is migraine with aura and without aura, and chronic migraine, and these are the other subtypes of migraine. Let's see about the pathophysiology. So, what happens or how this migraine happens? The trigeminal system. It is the key player in the migraine pathophysiology. The cortical spreading depression is a wave of neural suppression that explains the aura symptoms. So, CGRP is a neuropeptide involved in pain transmission and vasodilations, making it a key target for newer therapies. And chronic migraine develops due to the central sensitization and altered pain pathways. So these are the ways how the migraine happens. So one is the activation of trigeminal system, which will leads to the neurogenic inflammation. The next one is cortical spreading depression, which will leads to the visual aura. And the next one is the because of the increased CGRP, that is the calcitonin gene related peptide, which leads to the which it is a peptide which involved in pain transmission and vasodilation. And central sensitization is the develops to the chronic migraine development. So these are the how the migraine happens or develops. So this is what happens in the pathophysiology of the condition migraine. Next is the risk factors and triggers. So a migraine can affect anyone at any age, from children to adults, and here women are more likely than men to experience a migraine. So when you have a headache, specific nerves from our blood vessels send pain signals to the brain, and this releases inflammatory substances into your head nerves and blood vessels. So it is unclear why our body, the nerves from our body do that. So this is what happens in the condition. And what triggers migraine? So a trigger is something that causes symptoms to start. So some of the most common migraine triggers include stress, hormonal changes, or certain medications, changes to the sleep, weather condition changes, or too much physical activity, or like overexertion, or addictive substances like caffeine or tobacco, or if you miss a regular meal, or exposure to bright lights, loud noises, and strong odors. So these are the common migraine triggers. Migraine triggers which will trigger the migraine condition in the in your head or body. So migraine is often triggered by a predictable pattern, especially in women during menstruation. Other common triggers includes, as I've mentioned, the poor sleep, stress, fasting, and there are also certain foods like chocolate and aged cheese, like etc., etc., which will trigger the condition. And there will be a biological sometimes there can be because of the biological family history of migraine also, or it underlying medical conditions like depression, anxiety, sleep disorders, and epilepsy. And if the patient is a regular use of tobacco products, then there is also then also the patient can experience a migraine. And so these are the few things which can be a trigger factors, or the lifestyle things which will cause a migraine to the patient. And there are food things also. Food, some of the most common food which will triggers the condition is aged cheese, beverages like containing alcohol, chocolate, food additives like nitrates and msg, processed or cured foods like pepperoni, hot dogs. And there can be sometimes, because migraine can be caused due to fermented pickles, or fermented for products, so pickled foods, etc. And patient must be counseled. So while as I've mentioned now, the lifestyle things which will trigger the condition, food triggers, and hormonal factors like in case of menopause and menstruation, and because of the biological things, environmental changes. So these are the many factors which will trigger the condition. So you are the patient should be advised to be, or must be counseled to keep a migraine diary to identify what triggers their condition. So whenever a patient comes in, not only prescribing medications, or you have to advise the patient or counsel the patient to make sure, or make a note of what or the things which will trigger their condition, so that they can avoid such things in the future, so that they will not get the migraine again, or they will not suffer from the symptoms or the conditions again. So they can keep a distraction, or keep a distance from such things, or they'll, or also not only keeping a distance from such things, they should know what why why they experience such symptoms, and what causes that. So these things should be counseled by the doctors to the patient, along with the medications and other treatments. So moving on to the clinical presentation. So there are four stages or phases of migraine: prodrome, aura, headache, and postdrome. So what is prodrome? So prodrome, the first phase begins up to 24 hours before you experience a headache. So prodrome phase is a phase where, like before you experience a headache, there will be a phase which will begins up to 24 hours. That is the prodrome phase. In this phase, what you will see the things you will experience in these phases, I'll explain after explaining what are the phases. So that is the prodrome phase. Aura phase. So as I've mentioned before, an aura is a group of sensory, motor, and or a speech symptoms, or a visual symptoms that act as a warning sign of a migraine headache. So the aura phase, which can last as long as 60 minutes or as little as 5. So the patient might experience both the aura and the headache at the same time. So that is the aura phase. In headache phase, what happens is a migraine headache lasts between 4 hours to 72 hours. So that is the headache phase. And in the post-drome phase, the post-drome stage usually lasts for few hours up to 48 hours, and the symptoms feel similar to an like for example alcohol induced hangover, which is why the post drome phase is known as the migraine hangover. So it is like a, after the patient gets the migraine, once the symptoms reduces, the after phase of that is the post drome phase. So that is why we call this post drome phase as a migraine hangover. So, in each phase, the patient will experience different symptoms. So, the migraine symptoms vary based on the stage of the phase, and every migraine is different. And you won't necessarily experience symptoms during all four stages of every migraine. So, in the prodrome phase, there will be mood changes, difficulty concentrating, trouble sleeping, fatigue, nausea, increased hunger and thirst, frequent urination. In aura phase, what happens here? There will be muscle weakness, vision changes, and there will be tinnitus, like that is ringing in your ears, and sensitive touch, like feeling like someone is touching you, and numbness and tingling, difficulty speaking or concentrating. So this is what happens in the aura phase. In headache phase, so the head pain gradually gets more intense, and it can affect one side of the head or both, and it can occur with the other symptoms like nausea, vomiting, light sensitivity, sound sensitivity, and odor sensitivity. Sometimes you'll see maybe your colleagues or friends, they'll, if they have a migraine, you might have come to know, like they'll be having light sensitivity or sound sensitivity. So due to the sensitivity, their headache or the migraine increases, so the pain get worse. So the head, that is what happens in the headache phase. And the post drome phase, or the last final phase, the patient will be like fatigue, stiff neck, and sensitive to light and sound, and difficulty in concentrating, and they feel like dizziness and nausea. There'll be a cognitive dullness also. So these are the things or symptoms which we experienced by the patients in the post drome phase. So these are the clinical presentation. So you can ask the patient along with these while asking, while when the patient comes to you for consulting in OPD basis, you can ask what are the symptoms they are going through in what all phases also. So you'll come to know which phase, at which phase they are experiencing what and all symptoms. So knowing these stages or the phases of migraine is very very important to know about the clinical features of the conditions. So moving on to the diagnosis part. So diagnosis diagnose a migraine after a physical examination and a neurological examination. So about, you have to ask about the patient's medical history, biological family history, health history, and lifestyle habits, etc. So everything you have to ask related to the history or previous history, everything related to the patients. Like for, and also while taking the history, you have to ask the patient about the symptoms they experience, and ask them to describe the feeling and the location of the headache, where they feel headache more, and ask about how severe are their symptoms, and how long did the symptoms last, and did anything make their headache better or worse. Like for some people, due to, as I've explained the previous slide, due to the light sensitivity or sound or odor sensitivity, their headache can be worse. And for some people, some, if they do something, their headache will be better, like if they are off the light, or if they are not focused on the light, like for example, the patient is sensitive to light and sound and odor. If nothing is there, if they in the room, if they are off their light, they'll not be they'll get a much better feeling, or much better feeling of headache. So they feel better in such cases. So ask them what makes their headache worse or better. So these are the symptoms or things you have to ask while taking the medical history of the patient. And diagnosis is a clinical, and according to ICHT3, at least 5 attacks with specific features are required, and be alert for red flags effects like sudden onset neurological deficits or headache in elderly patients. So in these conditions we require imaging techniques to rule out the secondary cause. Sometimes the in elderly patients and all, neurological deficiencies, or when the patient suddenly gets symptoms of headache, then you require an imaging techniques to diagnose if there is any secondary cause for the conditions. And so that is the important thing. So note down their history and red flags also. Next is the investigation. So, how what all things you have to do while investigations of the condition? In most of the cases, there will be no investigations needed. However, if in case, as I mentioned, if there is any red flags are present, MRI is preferred. CT is used in emergency cases. EEG may help if there is a confusion with the seizure activity, like epilepsy and all. So always check fundus in chronic headache to rule out raised intracranial pressure. So fundoscopy should be done to rule out the papilledema, and to also to see if there is any raised IOP, ICP, intracranial pressure also. So these are the major important investigations you have to do in the conditions of migraine. Moving on to the management part. So the management part in OPD basis. So and first we'll see OPD management. So in the OPD, start with the NSAIDs or triptans, depending on severity, and use antiemetics if nausea is prominent. And for patients with frequent attacks, prophylaxis is essential, like propranolol and amitriptyline are commonly used. And counsel all patients about sleep hygiene, hydration, and identify their personal triggers. And in mild conditions, to mild to moderate, you can always advise NSAIDs like ibuprofen and naproxen. And in severe cases, you can advise triptans like sumatriptan, risatriptan, etc. And for adjuncts, you can advise the antiemetics like domperidone and metoclopramide. So these can be advised. And like there can be a common preventive therapy also in migraine. So common preventive migraine medications include, like in case of if there is a greater than or equal to 4 attacks in a month, you can all advise a preventive therapy, like anti-seizure medications like valproic acid, topiramate. And beta blockers like atenolol, propranolol, nadolol. Calcium channel blockers like verapamil. And monoclonal antibodies like erinumab, fremanizumab, etc. And anti tricyclic antidepressants can be advised like amitriptyline, nortriptyline, doxepin, etc. And serotonin and norepinephrine reuptake inhibitors like venlafaxine and duloxetine can be also advised. So and there are also lifestyle advice also. You can advise them to have a regular sleep and meals, stress management, and avoid the known triggers. So this is what or how you can manage the condition the OPD basis. So you have to keep in mind about the preventive therapy also and the acute management in the OPD management. Next is the IPD management. So, how you can manage the case in the IPD? So, in cases of patients with prolonged unresponsive migraine with vomiting, or if there is any secondary causes or suspicion of very serious pathology, admit the patient. Okay. And the indications. So, what are the indications of admissions? Like in case of status migrainosus and dehydration, vomiting, if there is any suspected secondary cause of pathology, neurological symptoms needing workup, so then you can advise, always advise the patient or admit the patient. And IPD treatment, you can advise IV fluids can be start, And IV management includes the fluids and anti-inflammatories and antiemetics. Then dexamethasone can be given to break the headache cycle. Antiemetics IV also given, and monitor for medication overuse headache. So sometimes there can be headache can occur because of the overuse of medication. So while doing the IPD management, always monitor for medication overuse. And you can also advise IV corticosteroid, for example dexamethasone, for prolonged attacks. So this is how you can manage the condition in the IPD basis. And next important thing is special population. So special population, we'll see pregnant ladies, women, children, and elderly patients. So treatment must be individualized. So in pregnancy, so I have marked here important points. So in pregnancy, the first important thing: avoid triptans and NSAIDs, especially in the third trimester or the third time late trimesters. Use paracetamol for acute attacks. This is for pregnant ladies. And for children, for the children, if they are in cases of children, they will be having abdominal migraine, cyclic vomiting. So these may present atypically. So in cases of this condition, you can advise children pizotifan or propranolol for prophylaxis. And in case of elderly, rule out for secondary causes, which is caused to the pathology, stroke or tumor. So rule out the secondary cause and do the management accordingly, and avoid sedatives and polypharmacy in cases of elderly. So for chronic migraine, one more important thing: for chronic migraine, Botox and CGRP targeted therapies are effective and increasingly used. So these are the important things you have to keep in mind in case of pregnancy, children, and elderly patients. So to wrap up the topic, to summarize it, migraine is a common and disabling condition, but it is manageable if approached systematically. And accurate diagnosis, early treatment, and lifestyle advice and appropriate preventive therapy can greatly improve patient outcomes. And always stratify whether a patient needs OPD or IPD management. So always differentiate whether that patient requires an IPD basis treatment or OPD basis treatment. So always remember these points. And diagnosis also is, it is clinical using the ICHT3 criteria. And treat with accurately with all the management part. And also advise and counsel the patients to avoid the triggers which trigger the patient's condition. So counsel the patient for such things. And also advice for their regular lifestyle. So proper lifestyle, proper sleep, proper routine, health care, food routine, diet routine, etc. should be done. So this comes to the end of our topic, migraine. I hope you understood the clinical part and all the management part. Thank you.